Hi. Hey, Travis.
Hi, Sue.
How are you?
I'm good. How are you doing today?
Good. Well, happy World Hemophilia Day. Here we are in red and ready to go. Um, so let's put up our first slide, Travis. We are here for a session that is entitled Care Available via HTCs, What They Do, How They Are Funded. Next slide, please. Care available via the HTCs. These are the folks that are going to be sharing information with you. These are wonderful colleagues across Michigan, and they're going to share perspectives regarding their HTC role. Each HTC also has a medical director, hematologist, who leads their team's efforts. I'm Sue Lerch, and in addition to my role as the executive director with our Michigan chapter, I also have the privilege of serving as the regional director with our Federal Hemophilia Treatment Center network across Michigan, Indiana, and Ohio. HFM serves as the Federal Regional Core Center for these states. Next slide, please. So from a historical perspective, clearly people with bleeding disorders require lifelong care and treatment. So you have a bit more of a background. We want to thank, in large part, Dr. John Penner, an amazing pioneer in hemophilia care. Dr. Penner was a hematologist from the University of Michigan, and he helped move then from University of Michigan to Michigan State University. Back in the mid-1970s, Dr. Penner worked with the U.S. Congress to authorize a national network of hemophilia treatment centers. So this HTC system that we have across the country actually originated here in Michigan within our region. Do you want to advance? There we go. Congress authorized it. That was in the 70s. And it continues today. So we're grateful. It's really, really grown. As of 2021, there are now more than 140 hemophilia treatment centers that serve people with bleeding disorders across the country. There are 8 regions that are considered Health Resources and Service Administration maternal and child health regions, and there are 10 Centers for Disease Control regions. For us, here in Great Lakes, Region 5 East, our HRSA and CDC regions are one and the same, Michigan, Indiana, and Ohio. My colleague, Travis Tussing, is going to explain what it means for HFM to actually be the Regional Core Center. There you go, Travis.
Thank you, Sue. I really like the map that the CDC provides as part of their HTC directory, really outlining the different regions across our nation. I think you mentioned that there are 140 HTCs across the nation, which it's very tough to display on this map. But I really like this map and how it shows how we're broke up across the region. We just stated that HFM serves as a regional core center. But what does that mean? What does that mean for HFM? What does that mean for our HTCs? And what does that mean for you? HFM receives 2 federal grant awards from the Health Resources and Services Administration and our Centers for Disease Control and Prevention. We serve as a pass-through entity for these grants and provide the funds that we receive back to the HTCs themselves. However, beyond just the funding, we provide grant oversight, technical assistance, and guidance to ensure that we meet our federal goals and objectives. If you had the opportunity to attend the community count session earlier today by Dr. Byams, you learned about that program. The CDC grant is specifically to support the community counts program. If we looked at our HRSA/MCHP grant, it's really a much wider and broad grant. If I had to narrow it down to one statement on what the purpose of that grant is, it would be to ensure that our patients have access to comprehensive multidisciplinary care within our region. So here's kind of a basic graphic that describes how flow works within the federal partners, our regions, and our HTCs. Funding, technical assistance, and guidance comes from HRSA, down to the regions, down to our HTCs. And it's tough to portray this, but our HTCs are really doing the bulk of the work for these grants within the HTCs. They're out there seeing patients, they're enrolling patients in the community counts program, and really in contact with you on a one-on-one basis throughout much of the year. They take the information that they collect as part of our grants and report that back to HFM. HFM and the other regional core centers analyze that data and report back up to our government partners. We're able to include both the data information, particular barriers to care within our regions, and the successes that we've had related to those grants. So if we've looked a little bit, very briefly about how our grants work. I wanted to talk a little bit about the funding in detail, a little bit more. We know that the HTCs receive a little bit of direct grant funding via the 2 federal awards we have. In addition to that, however, participating HTC subawardees, particularly in the HRSA subaward, are eligible to participate in the 340B drug pricing program. This program allows participating HTCs to purchase outpatient drugs from manufacturers at discounted prices. Funds generated from these programs are required to be used specifically by our HTCs to support our federal awards and their goals and objectives. And again, much like the grant programs themselves, these 340B programs are subject to oversight and approval, not only by HRSA, but by our regional core centers as well. So we really took a brief look about HFM's role as regional core center and how we operate. I wanted to take a step back and look at our region as a whole. Sue mentioned that we encompass Indiana, Michigan, and Ohio. Indiana has one HTC that provides statewide outreach all across the state. Here in Michigan, though, we have 10 different hemophilia treatment centers that are providing care for our patients across the entire state. And if you look down to Ohio, there's an additional 8 HTCs. Of the 140 HTCs across the nation, 19 are here within our 3 states alone. And I think that's quite amazing. You look at the small geographic footprint that we have in Michigan, Indiana, and Ohio, but we really have quite the representative care in our HTCs and our patient population. Sue mentioned some of our HTC staff members earlier. I wanted to just point out some of our regional core center staff for you so you know who's working with the HTCs on a regular basis. Sue serves as our regional director. Dr. Amy Shapiro from IHTC serves as our regional medical director. I'm our regional coordinator. Sue Adkins serves as our regional core center specialist. And then Lisa Clothier provides regional social work services to our HTCs. But beyond that, many people at HFM also have additional roles and provide support to not only our regional core center operations, our HTCs, but also helping on educational programs like this that helps support our grant goals and objectives. I'm very appreciative of the support that they provide not only to me, but to the HTCs in our region. So we did a brief look at HFM as regional core center, what our region looks like. I want to now kind of focus on HTCs themselves. If you were able to attend our lunchtime session, Dr. Mullins mentioned NHF's MASAC, the Medical and Scientific Advisory Council. He said that they provide guidance to HTCs on patient care, treatment regimens, and many different subjects. If you look specifically at MASAC 132, that is the standards and criteria for the care of persons with congenital bleeding disorders. That's really our roadmap for HTCs. It tells us how they operate and what staff members they have. It describes the different roles and who you'd see if you went and attended a comprehensive visit. Listed here are some of the core team members. Sue mentioned that there's a medical director at all the HTCs, but the team has each HTC has a very diverse multidisciplinary team as well, which includes program coordinators, nurse coordinators, physical therapists, and then even more extended team members that you may not see every time you go into an HTC, but they're offered there, such as nutritionists, genetics counselors, and dental hygienists. We really wanted to take the opportunity today to invite some of those core team members and extended team members to talk about their role at the HTC, what they do at the HTC, and maybe some of the things you didn't know that they were doing to provide care for you behind the scenes. And with that, I'd like to turn it over to Nancy Inverso.
Hi, it's nice to be here today. I'm so excited. My role I'm at the Bronson Hemophilia Treatment Center in Kalamazoo, Michigan. And my role is program manager. And so that sounds kind of weird, but I'm a nurse, really, is the bottom line. But I really think of nursing as a unique job, more the jack of all trades, because we have to do a whole bunch. Now, granted, you're going to meet a lot of other people today, and we couldn't do our job without them beside us, helping us take care of all of our patients. But I just want you to know a few things that I do day in and day out with my coworker, Nurse Jen. The two of us are the nurses at the Hemophilia Treatment Center in Bronson. Some of these things I'm sure you're very well aware of. You know, we take phone calls, we see patients in clinic, we do assessments and education and all the things that you think about a nurse when she does her work, he or she, I should say. But we also do different things like we plan procedures and help with surgical procedures. We also do school visits, or I talk to daycares to help when kids are starting a new school or going to a new daycare and the daycare providers are anxious or nervous, caring for a child with a bleeding disorder. We work with your factor pharmacy to make sure that they have a script and they have all the information so that you can get your orders shipped when you need to. We work with insurances. I'm sure you've all heard the glorious term prior authorizations. We spend some time on that some days. Some of the things you may not know that we do, for example, in a pandemic, who would have thought that I would be working from home and talking to people about, do you have enough factor? What if the pharmacy can't get you factor? This is a pandemic and we don't know what shipping's going to be like. Or I bet daily we get phone calls on, what about the COVID vaccine? And is it safe? And should we get it? And we spend time educating our patients on the important information that they have questions on. Some of the other things that we do day in and day out are we coordinate procedures and things with other HTCs and other hospitals. Not everything can be done at our local hospital. And so sometimes our patients travel within the state, sometimes they travel within the country. And we coordinate with HTCs across the country and in our state to make sure our patients get the care that they need to get. We work with, like ERs and surgeons and dentists and all different types of things. We take calls from PCPs, which are your primary care doctors, from the ER, from the dentist, while you're right there with questions about what can they do and what should be done. As program manager, though, I also act as a business person. So I have responsibilities to the financial side of our hemophilia treatment center. So as Travis and Susan mentioned earlier, the grants that we get through the CDC and through Maternal Child Health Bureau, I'm responsible for creating the budgets and making sure that we use that money appropriately within those budgets. I'm also a person who does works with our 340B pharmacy. We have contract pharmacies that we work with, and I'm responsible for all the financials from our hemophilia treatment center standpoint. So those are kind of some of the other jobs that I do. But the bottom line is we're here to take care of patients and we want to do what's best for all of you. So my role may be unique and may be creative and may be fun for me, but it's not as common as what other people may think. So I hope I gave you an idea of what my role is and how we do our job. And I'm going to hand it off to the next person. Thank you very much.
Hi, everybody. I am Dave Rushlow, and I am the social worker and program manager in Traverse City. And I've been at our treatment center for about 28 years. And in listening to Nancy, you're going to hear a lot of the same things because it's amazing how our roles actually do a lot of, we cross over and do a lot of the same things, even though I'm not a nurse. And anything that medical comes up, I give to my nurse, Kathy, who's my nurse coordinator. So we work, pretty close together. I'm the program manager. do a lot of the same things that Nancy does in terms of the business side, as she talked about. But in addition, what I do as a social worker is we do a lot of problem solving. So it's, we get calls for so many different things, and that's the beauty of working with all of you in hemophilia, is no 2 days are the same. So one of the big things that we do in working with families is we work on insurance and work on finances. We try very hard to make sure that you're covered for your bleeding disorder meds. We want to make sure that you don't have any copays or very little copays. And we work pretty closely with the insurance companies and then also with the payment assistance programs through the pharmacy, or excuse me, the different pharmaceutical companies. So that's our big thing. And we also want to make sure, for those of you who are on children's special health care, we want to make sure that you keep that so that it will cover your bleeding disorder. Another thing that I do as a social worker, and most social workers do in the HTC, is we are always looking at transition. And I don't know if you had an opportunity to be on our session last night and talking about transition, but we're always wanting to talk about whether your child is 5 years old or whether you're 18. We want to talk about you becoming independent so that when you leave mom and dad's house, or when your child leaves, they will be very independent and be ready to go off to school or trade school, technical school, vocational school. So always really looking at what can you do to always become more independent. The other thing we do is we address mental health. So we do a lot of counseling, and for the social workers who don't do counseling, they will make referrals out into the community. So we're always assessing for depression, anxiety, any substance abuse, coping, relationship issues. We work a lot with the teens and with intimacy, and even talk a lot about sex. We're the people who feel comfortable with that, and it's just kind of how we roll. And so hopefully we make that comfortable for when you come in. The other thing that we do, as Nancy had mentioned, we do home visits. We do visits with employers, and we also do school visits. And we help the school system develop behavioral plans, and also we do education for the teachers along with the nursing staff. And then we also help develop a 504 plan, which is a special accommodation plan that if your child is in school and if they have a bleeding disorder and they have to take factor, or they can't play a sport, or they have to sit out with in phys ed because they've had a bleed, we make sure that your child's going to get everything that they need, and they're not going to be neglected at all, or they're not going to be punished in any way from the school system. So it's a really a big thing that we do an awful lot of, especially in the fall. The other thing that we do is we are always looking at scholarship information to give to juniors, seniors, and people of college age, also to siblings, to hopefully reduce the cost of a college education or a technical school. There are an awful lot of scholarships out there that aren't just for college, for your typical college program. There are many for technical school or vocational school, so keep that in mind as well. And a lot of people forget that. So there's a lot of money out there. The other thing that we do for social work is we help to write grants, we do research, we have developed, as Nancy talked about, a 340B pharmacy program. I manage our pharmacy 340B program in Traverse City. Do a lot of program development, bring families together, have educational programs, picnics, golf outings, putt-putt golf, things so that we can keep all of you interested. And then the other thing that we do too is advocacy. We work with the ER, we work with other physicians, We go down to Lansing and make sure that children's special health care is safe, and try to educate our legislators. So the last thing, we do many other things, but that's just really the tip of the iceberg. But another thing that I do as a social worker, is when the kids are learning to infuse, they like to practice on my arms. So we're full service. So my arms get beat up, and needles don't bother me, and I'm a good practice. So anyway, that's it. And thanks for having me as the social worker on the team. And I'm going to pass it off to Sherry. Thanks.
Hi, everyone. Thanks, Dave. I am really happy to be here to represent the physical therapists at the treatment center and talk to you today about what my role is. At the Hemophilia Treatment Center, physical therapists may come in from a variety of backgrounds. We may have pediatric background to begin with, or geriatric background, or sports med background. But once we get to the Hemophilia Treatment Center, our job is to learn about how to care for the musculoskeletal problems that come up from having a bleeding disorder. And most of you probably are already aware of that. But our primary goal is to improve the quality of life for those of you who are dealing with musculoskeletal consequences. The Hemophilia Treatment Center physical therapists, the time that we have in the clinic varies from center to center. Some hemophilia treatment centers just have a PT that comes in and out a little bit. Some have a full-time PT. Some are lucky enough to have more than one physical therapist, believe it or not. But our job is to cover a lot of bases for you, and some of them I know you will be aware of and know that is going on, and some of them I know that you may not know. When you come to the clinic, you will interact with us, and we will take your range of motion measurements and look at your strength and look at your functional mobility, look at your balance. We may look at your developmental level. If you're a child, we're looking at, are you learning to walk and run and jump and all the things that we would expect you to be able to do. We are looking at whether you have any abnormalities of your walking ability. Do you need any assistive devices? So we're assessing a broad number of things when you come into the clinic. We are really interested in bleeding history and recognizing bleeds and preventing bleeds and identifying causes of bleeds. And I like to think of that as being like a detective, so to speak. Like we ask a lot of questions to try to figure out in mystery bleed situations what actually caused the bleeds. We use our expertise to examine joints, to help identify if a joint is bleeding or if there's arthritis in a joint or other problems that aren't even bleeding disorder related that might be affecting the musculoskeletal system. We like to talk about your activity level and what activities you're choosing. We like to know if you're limiting your activity because of joint bleeding or muscle bleeding or menorrhagia or even nose bleeding, or if you're limiting activity because of joint damage. We want to provide recommendations for you about activity and work with you to help you find the activities that are safe and appropriate for you. We participate in the decision-making progress about your ongoing care as part of the comprehensive team. And you can hear from the other speakers already that, it's a collaborative approach and we're overlapping a lot in how we provide our care, but we work very closely with the other team members. Part of the physical therapist job also is determining whether there are other specialists outside the Hemophilia Treatment Center team that you might need to see, like an orthopedic surgeon or a physical medicine doctor, a pain specialist, or an occupational therapist if you're having difficulty with self-care, or if you're a young child with any kind of sensory issues. We may send you to see someone who's a specialist in pain management, or a specialist in nutrition or weight management, or pelvic floor complications that go along with menorrhagia. So we help to identify whether there are other professionals that could be helpful to you in your journey. We really love providing education, both to you and to other providers who take care of you. So behind the scenes, we might be involved with advocating for your participation in a gym class or in a sport by teaching your coaches or your teachers about bleeding disorders. We may be providing education to the school like Dave spoke of, like in your 504 plan or your IEP plan. We may be helping to provide advice for modifications at your workplace, or helping you know if it's safe to return to work after a bleed, or choosing a job that's appropriate for you with your joint condition. We're often involved in helping develop education programs on a broader scale for people with bleeding disorders and other providers. And we do a lot of educating of other physical therapists in the community, especially if we refer you to one in particular and we need to teach them about hemophilia. Because although in my example, I'm a pediatric physical therapist by training, I understand a lot about bleeding disorders, but I don't want to be the one to take care of your ankle sprain. So I'm going to talk to the physical therapist about ankle rehab, and I'm going to teach them about the hemophilia aspect of that. The bottom line is, if you have a bleeding disorder that has any implications on your musculoskeletal health, I recommend that you talk to a physical therapist, have an evaluation by a physical therapist. It's really a very important component of your care. And while I have your attention, there's a few things that your physical therapists want you to know that I just wanted to go over today. The first is, we really do want to help. That's our priority. We want to work with you and help you reach and maintain your full physical potential. And you may not believe it, but it really, really pains us when we have to advise you against things that we know you want to do, but we are concerned that they would be dangerous for you. We want you to be comfortable talking to us about any activity that you're doing, even if you think that we're not going to like it, because we want to be able to work together with you to have you continue a safe and healthy active lifestyle. It requires open communication. Also, we really want to know what you need and not just what we think you need. So please reach out to us and communicate with us. You really are our best teachers, and there's so much learning that is going on in the hemophilia world these days. We really need to collaborate. I consider myself really lucky to be part of the Hemophilia Treatment Center team, and I get great satisfaction participating in your care. Thank you very much, and I'm going to pass this off to my colleague, Becky.
Hey, Sherry. Thanks so much, and good afternoon, everybody. I'm Rebecca Hauke from the University of Michigan HTC, and I'm going to talk briefly about the role of the data coordinator at HTCs. And the data coordinators use a database called Clinical Manager to collect and maintain your bleeding disorder information. And this is a database that was designed by and for the 140 HTCs around the country to ensure that we are collecting the most useful clinical information about bleeding disorders all in the same way. It is specific to the care and treatment of bleeding disorder patients. The data coordinators are the gatekeepers of the information that goes into and out of the clinical manager database. And even though all of the HTCs use the same database to enter information, we all function in a little bit different ways. Many of the data coordinators are behind the scenes at the treatment center. Some of us you see during your visit. At Michigan, we do have a dedicated data coordinator, but for some, the nurse serves a dual role of nurse and data manager, and kudos to them. I'm not sure if they get a double pay, but they should. Nancy and Jen, Cindy, all you out there. And anyone who's ever had a visit at an HTC knows that the HTCs collect a lot of data. And the importance of the data we collect and the data quality cannot be overstated. So by using the Clinical Manager database, we are able to collect the data needed in a standardized fashion and then reporting this data out. And this data is used to provide statistics and metrics to many granting and advocacy agencies that Travis talked about, including the CDC, MCHB, NHF, and regional and local foundations. And this data is then used to help the community as a whole gain a better understanding of bleeding disorders and then uses that knowledge to improve care. So the data coordinators are here to provide support to the HTC clinicians and to submit this data as accurately as possible. And we are able to give the clinicians detailed information when they might have specific questions, such as, how many hemophilia patients over age 12 do we have? How many of our patients have an inhibitor? Who's on home infusion with VWD, etc.? And some of these questions help decide if we will participate in a clinical trial. Some help decide if there are enough patients to perhaps start a patient focus group and the like. And any data that we collect is used specifically for your care or used for reporting purposes in an aggregated manner, which means it's included with everyone else's data with no identifiers attached. No one knows whose data is whose. So when the CDC wants to know how many hemophilia A patients are treated in Michigan, they are given a raw number and nothing else. So we also collect data for specific research projects, but only after you provide informed consent. And data coordinators also use the database to send out mailings to our patients, either by regular mail or email. And just a side note to those Michigan Medicine HTC patients, you should be receiving your patient satisfaction survey in the mail in the next couple of weeks, or you should have received it via email already. So we hope that you will complete them. And then so anytime you see reporting on total numbers of bleeding disorder patients, how many have VWD or hemophilia, how many treat at home, how many under 2 years old, etc., know that you are part of those numbers and that they were provided by your data coordinator. So I hope this gives you a little insight into the job of the data coordinators at your HTC. And as always, if you need any information, your data coordinator probably has it. Thank you, and I will pass it off to Mike and Stephanie. Thank you.
Hey, thanks, Becky. So I'm Stephanie Raymond, the Executive Director at Cascade Hemophilia Consortium, and that is our Pharmacy Director, Mike Altese. I'm just going to take a few minutes to talk about how we work with your HTCs, and then I'll throw it over to Mike to talk a little bit more about pharmacy's role. As one of the earliest nonprofit bleeding disorder organizations designated as a covered entity under the federal 340B program, Cascade has been providing care, services, and support to the community since 1994. We are part of the treatment center network in our region and have partnered with your treatment center staff since the very beginning. As Sue and Travis mentioned earlier, the 340B drug discount program is a federal government program created in 1992 that requires drug manufacturers to provide outpatient drugs at reduced prices to eligible healthcare organizations and covered entities like Cascade and your treatment centers. The income generated by those discounts allows us and other entities to support and expand access to multidisciplinary care and services to the bleeding disorder community. Cascade's primary goal is to provide excellent care and services to patients, while at the same time ensuring that our 340B savings are passed on to you and your insurance companies. Our second goal is to support patient care and education in our region. And we do this by using all of our revenue after expenses to provide assistance to our treatment centers and chapter foundations like HFM. We provide support to your treatment center so that they can provide you with the great care and education that you have come to depend on. We also support many of the fantastic educational events like SpringFest and all the incredible camp programs provided by HFM, as well as emergency financial assistance. And over this past year, we were able to provide increased assistance to HFM and other foundations to help families and individuals with financial difficulties that were brought on by the COVID pandemic. Our pharmacy team and our social workers and our nurse work hand in hand with your treatment center team to make sure you receive the best care and services available. And with that, I will turn it over to Mike. He's our Cascade Pharmacy Director, and he'll share a little more about the important role that pharmacy plays in your care.
Good afternoon. Thanks for the opportunity to be here. I may be the person that you talk to each month or so here at Cascade, for those of you who are sharing with Cascade. But we start off by trying to get involved with you, as well as your treatment center, as well as your insurance companies and things like that. We're kind of got our hand in all of those pots, whether that's a good or a bad thing. We start off talking to the patients. Those of you that are talking with us know that we have those nosy questions that we're asking you each month about how many doses you have on hand, if you've had any recent bleeds, things like that. In some cases, depending on which treatment center you're going to, we may be the only person that you're talking to monthly, so we want to get as much information as we can and share that information back and collaborate with the treatment center to make sure that they're aware of what's going on if you do have a bleed going on, or if there has been a change in your home life or something like that. We can help share that information back and make sure that everybody on your care team is aware of everything. If there's adherence issues, if we notice that maybe it's been 6 or 8 or 10 weeks since you last ordered, that may be an opportunity to reach out to you and see what's going on. Maybe it's just because it's a pandemic and you're not moving around as much, and everybody knows that you're, instead of dosing 3 times a week, you're only dosing once a week because you're just not as active as you were, things like that. So that's information that helps us, and we can help share it back to your treatment center. Anytime that we get any information from you regarding changes in your treatment plan, if your address has changed, your insurance changed, obviously that's a big one everybody's mentioned, prior authorizations and things like that. So anytime the insurance changes, getting that information back to us and back to your treatment center is very helpful, because there are times, sometimes each month the insurance company may need specific questions answered. Again, that's why we're asking those nosy questions like we do each month. We also provide information back to you. We may be reaching out when there's recall information, or if there's delivery problems, if there's a snowstorm, or if a delivery driver can't find your house and things like that. Obviously, we're going to reach out to you and try and make sure we can get that information back to the patient, or back to the driver as needed. Obviously, we do a lot of collaboration with the treatment center. We're involved. We try and be involved with discussing the therapy. If there's a dosage change, or if you're changing to an entirely new medication, making sure we're as far ahead as we can be with the treatment center, and making sure that any plans are in place, so that we know, again, insurance-wise, how long this may take to get it approved and things like that. If there's preferred supplies that maybe, again, you learned to infuse at camp, or you were trained at the treatment center, you have a particular butterfly that you prefer, or you have a particular Band-Aid, you want a superhero Band-Aid, we'll work as much as we can to try and make sure that we can get that Band-Aid for you. Again, as everybody has mentioned, there's a lot of facilitating back and forth with insurance companies and things like that. So we'll interact with your treatment center. We may need to get clinic notes, or the most recent other notes and things like that the insurance company may need to approve the treatment for you. Again, as I mentioned, recalls and things like that, it's another, if there is a recall, we're going to reach back out to your treatment center and let them know in case that there's a therapy change that they want to make, or if they just want to, obviously we want to make sure that they're aware of which patients are affected by any particular recall or shortage. I don't know, there's a pandemic going on, so there has been a little bit of a shortage of syringes, but we've, one of our pharmacy technicians bent the arm of one of our providers, and we were able to get some more in stock, so good things going on there. But yeah, I think I'd like to say, maybe I'm speaking just for me, but I think we have a great interaction with the treatment centers in the region. It's probably a day doesn't go by where I'm talking to at least one of the nurses, or one of the social workers even, from one of the treatment centers for various reasons, as we've talked about before. Outside of the patient and the care team, we're also, again, everything points back to insurance at times. So there's a lot of interaction. We may be the first one to know that a new prior authorization is needed. We've got a whole team of people that stay up on that, notice when an authorization is going to expire, and point back to your treatment center to get the information that we need ahead of time to get that going. As I said, there are authorizations each month. Some insurances require this authorization each month. With each fill, we have to meet a certain guidelines. We have to be within 3% or 1% or something like that. So we're working to stay ahead of the game, try and get the best potencies that we can from the manufacturer, make sure that we can get the best dose to you that we can, that hopefully doesn't have too many vials to make up a dose and make your injection process worse than it needs to be. It's more than just, we've got full and part-time pharmacists here, but we've got a giant staff behind them, behind us, behind the scenes doing a lot of that, from the initial intake team. We've got social workers and nurses that are gathering all the information that they need from your history to make sure that we're on top of that. We've got billing and people down, further downstream to help make sure that there's no problems there. Nobody wants to get a surprise bill from an insurance company when we all thought everything was going to be golden. We work quarterly, at least we are providing mailings and newsletters to try and help educate you about if there's changes if there's new therapies, if there's anything that's going on. We'll each quarter we've got an exciting newsletter that will at least have Stephanie or mine or Colleen's or somebody's picture on there to brighten your day as best we can. So again, I think, as everybody has said, it's just a giant collaboration, and Cascade and the pharmacy that, whichever pharmacy you're working with, I think is going to try their best to get involved as much as they can to stay in that game and make sure that you're getting the best care that you can. I think that's about where I was going to go. I don't know if Stephanie had anything more to add. Otherwise, I think we can go back to the main stage.
One thing real quick, I just wanted to say, I think you've all heard everyone mention at least once or twice the word authorization. So that is a very important and time-consuming piece of what our team does every day. And we do collaborate and work very closely with the treatment center teams to get those authorizations so that you don't notice any interruption in your care. So I think we're good. Thank you for everybody for having us here. And who are we throwing it back to? I think we're
going back to Sue.
Thanks.
To unmute my mic. There we go. Hello. He waited until I got my mic ready. Thank you all. It was just a really informative and exciting presentation by all of the HTC staff that were here today. We do have some questions, but before we get started, I was the camp health officer for many years, and I could always count on Cascade. I would call the last minute when something fell apart and we needed factor. They would drive it across the state if necessary. And they also always sent candy to the staff. So that was very meaningful for all of us in the health center. And I thank you. And you have many thank yous in the comment section that you probably weren't able to read because you were on the screen. So we have our first question, and I believe that we'll be showing it on the screen. Is that correct? Everybody's coming on board. And here is that's not, okay. Let's start with this question. This question is for all of you. What is your favorite part about being involved on the HTC side of things, if you haven't already said that? I'll go. My favorite thing is the community. It's the patients, it's the staff, it's the people, it's the drug pharmacy people. It is everybody. This community I joined about 5.5 years ago, and I am so happy in my job. And I love working with these patients. You guys are the best. And so thank you.
One thing I would say, again, we're a little outside the exact HTC, obviously, but we are certainly involved in the community. And I came from working in industry before I came and started working for Cascade. And I'll admit that hemophilia and bleeding disorders was not my #1 priority. It wasn't the main thing that I learned in pharmacy school or anything like that. And it certainly helped to have such a strong community, as Nancy said, that, I mean, there's no question that the patients and their parents knew maybe more than I did when I first started, and were educating me about what they needed and when they needed it. And, you know, that's, although it's a little intimidating, it certainly is amazing, I think, that the education that goes on from the treatment centers and that the patients and their caregivers take on themselves to make sure that they're aware of everything that's going on. It's really impressive. I've never seen another area of therapy where everyone is on the ball as they are in bleeding disorders.
I would like to say that I agree with one of my favorite things being the community. Another one of my favorite things is just that there is something new to learn every single day. It's never boring. It's there's always a challenge. There's always someone wonderful new to meet, wonderful to work with. Professionally and personally, it's been an amazing journey for me. And this is my 25th year with the Hemophilia Treatment Center. And it's just been great.
I'll second that. This is also my 25th year here at Cascade. And I can't imagine working anywhere else. I love coming to work every day. It's different every day, like you've all said. I've made friendships, long-time friendships and relationships, and it's wonderful. Everyone that I've worked with over all these years have just been fantastic. And the families, I have to say, because I've been here so long, I have seen little kids, you know, that I've gotten to meet, and they're in college and now they're married and having children. And I haven't gotten any older. But yeah, that is amazing. That's the amazing part.
Yeah, I would just have to say I third that. You know what you and Sherry said, Stephanie. It's everything. It's the families, the relationships, the staff. No 2 days are the same. It's, you know, and where did 28? I've been here 28 years. Where did 28 years go? It's just been a great journey, and I can't imagine doing anything else either. And I hope that I don't have to. So, yeah, it's just it's very, very gratifying. And I'm very mindful of my gratitudes for my role. So.
Thank you. We have another question, and okay. Excuse me. Dave's example of letting kids stick him is over and above awesome. Can our HTC community share some of their most unexpected things that they have found themselves doing to help patients?
Well, I can share something unexpected, although this isn't really so much a physical therapy thing, but this had to do with hanging out at hemophilia camp, where I got to spend a couple nights sleeping alongside a little homesick boy in the health center because he was having trouble adjusting to being at camp. And I got to know him really well, telling stories through the night and lying there on a hard floor in the health center. But that kind of connection is just precious to me.
One thing I don't know, I know this is before I started, maybe Stephanie can tell with better detail, but there was a delivery company strike. I don't know if it was FedEx or UPS or who it was, but you know, at that point, Bill and Stephanie and other staff or whoever was needed, you know, just loaded up their cars and did the deliveries themselves, you know. So.
Yeah, that was a UPS strike. And Bill Sparrow, who was our founder and first executive director, we split up our region. I loaded up my van and drove to Ohio with a van full of deliveries, and Bill delivered here in Michigan. And if we didn't do that, there was no other way to get those deliveries out. So yeah, we got to meet a lot of folks and put some miles on our cars.
There was one comment about in the chat about some of the different things that you needed to do, and she tried to get factored to a homeless person. That was one of the hardest things to do. And her comment is Cascade rocks. And we have another question that I wanted to bring up, and it is, do HTCs collaborate across the region? Do they share experiences, information to help each other? And I'm going to call on all three below the line, which would be Sherry and Dave and Nancy, because they all can share that. Sherry, you want to go first?
Oh,
okay.
Sure.
Go ahead, Nancy.
Oh, yeah, Nancy, go ahead.
Okay, so absolutely, I can't tell you. I mean, even this week we did a call. Our email question came out about what was our experience doing something, and could we share with another treatment center? And it was sent out regionally, so we all had the opportunity to, help a colleague out, and that was wonderful. I send patients to Mayo, and I've had patients have surgery at Beaumont and at Henry Ford and at U of M, and we talk all the time. So we collaborate so closely together. It really is a family in many ways. You call your brother or sister in the team and say, "Help me out. What's going on?" Or "How can I help you?" And I'm also on the National Nurses Working Group, and we do that even at a national level. And so absolutely, from the nursing standpoint. Dave?
Yeah, well, from the social work standpoint, we have a social work meeting with all the social workers. We get together on a Zoom call once a month, and then with the region social workers, we also get together, and we troubleshoot and we collaborate, we support one another, but constantly in touch, sending emails about if I have an issue, and I don't have to reinvent the wheel. You constantly are getting feedback. I call Stephanie a lot at Cascade about insurance issues, or call their social workers. Even though, again, I'm not a nurse or the physician, but my path crosses a lot with Mike, because we have questions about medication. Recently, last week, I got a call from a patient in Florida who used to be up in northern Michigan. We referred him down to Cindy, and so I'm collaborating with nurses. We have another gentleman moved to the UP. I'm collaborating with that HTC from Chattanooga. I mean, it's constant collaboration.
My collaboration started my first week of work when some of you may know Steve Houghton, who was a physical therapist at Michigan State University, and he was my mentor in teaching me to begin with about bleeding disorders. But constantly since then, I'm in communication with the therapists around the region and around the country. We're a small group, and I'm communicating with other HTCs when patients have been seen at more than one facility. Just like the other providers, we share patients sometimes, and that can be a really great collaboration. And over this last year, especially, HFM really helped us by Sue Adkins in particular, helped us facilitate a physical therapy virtual group, and we've been meeting on a very consistent basis to be sure that we're doing everything we can to optimize care for our patients in the region. So the collaboration is also one of my favorite things about the hemophilia community and the bleeding disorders community.
Becky, would you like to add? to that question about what the data coordinators do across the region?
Sure. So yeah, we also have a monthly meeting that Sue facilitates for the data coordinators. We share, trials and tribulations about what difficulty we're having, entering data, getting data, how to do it best so that it's accurate and we're not redoing work. And just trying to help each other out and, take care of the patients.
Thanks. And I know, Stephanie, you probably wanted to say something as well, because before we were under COVID, we had regular meetings as well that you participated in, you and your staff participated in.
Yeah, we, like everyone else has mentioned, just the fact that we can pick up the phone anytime, during the day and call each other. Everyone is just right there to help and help you problem solve and answer any questions, that you may have. Our region is just awesome.
Mm-hmm.
Great. Lots of great comments. You are all amazing. Love hearing about your personal stories. I love it. Teamwork makes the dream work. And I think that's what you were all saying, that the longevity of staff in the HTCs is quite amazing and has been really helpful to patients, but also we stay in hemophilia because we gain so much from the patients themselves and the consumers. So we all want to say thank you to you, participants, for teaching us and going along our journeys as well. Travis, did you want to make a comment?
I think you said it, Sue. I'd like to thank everybody for participating. I thought it was a great session, lots of discussion, lots of questions and comments. But I think Stephanie said it best. Our region's awesome. That's because of the HTCs that make it up, the staff member at those HTCs, and the patients across the region too. Everybody brings it all together. I think we are a great region. Thank you so